to interact with the eminent academicians in the discipline of psychology. Now, I would like Ms. Aisha to introduce the guest speaker to the audience. Over to you, Aisha.
Thank you, Dr. Ninad. Am I audible, Ninad?
Yes, you are, Aisha.
Thank you. Dr. Azizuddin Khan is currently professor in psychophysiology and cognitive psychology at the Department of Humanities and Social Sciences at Indian Institute of Technology, Bombay. He is heading Psychophysiology Laboratory. He was visiting faculty at the Department of Psychology, University of Jyväskylä, Finland from August 2004 to December 2005. Aligarh Muslim University, India, in 2015 to 2017. Department of Psychology, University of Warsaw, Poland, 2018. He has research interest in the field of environmental psychology, polar research, developmental neuropsychology, emotion regulation, or prospective memory, and developmental dyslexia by using biofeedback and electrophysiological method. His teaching interest lies in the field of cognitive psychology, educational psychology, human cognitive processes, developmental neuropsychology, biological psychology, cognitive ergonomics, and research methodology. Dr. Khan has done his graduation and post-graduation from Aligarh Muslim University, AMU, Aligarh, with first division in 1993 and 1995, respectively. He has qualified UGC NET Junior Research Fellowship in December 1998. He has completed his PhD from IIT Kanpur on the topic of temporal aspects of prospective and retrospective memory in 2006. He has also worked as a researcher at the Department of Psychology, University of Jyväskylä, Finland, from August 2004 to March 2005. Dr. Khan is an eminent psychologist, prolific writer, and author of many books. He is the recipient of several visiting research fellowships, such as Hermes Fellowship, DAD, INSA, EMI-NTE, ICSSR, etc. Dr. Khan has published more than 4 dozen peer-reviewed international journals, especially in the field of emotion regulation and developmental disorders. We are very grateful for you to be here today, sir. Over to you, sir. Thank you.
Thanks, Aisha and Ninad. So today's topic is basically quite interesting in the sense that like this area is not well researched, not only in India but even abroad. Recently, the area has picked up the the interest by especially psychologists who are into prospective memory and neuroscientists. So as the title suggests that the topic is prospective memory and aging in medication adherence and experimental investigation. Actually, the term medical adherence and medication adherence, though they have different meaning or implication, but in psychological literature or even neuroscientific literature, they are used interchangeably most of the time. So I'm using over here in a similar way. I have organized my talk in the following way. That is, first I'm going to talk about introduction, and within introduction I will be talking about what does it mean by medical adherence and why it is important, and what kind of implications or situation may arise if patients are not patient do not adhere prescribed medication regime. Then I will be talking about how aging and prospective memory may influence medical adherence. And then I will be discussing very shortly about one of my study on aging and prospective memory with respect to medical adherence. So what does it mean by medical or medication adherence? Basically, it refers to the patient's ability and willingness to follow recommended health practices. If you look this definition, it looks like quite broad, but actually medical adherence is a broader term. It is not simply following whatever physician prescribes to a specific patient. And it has been observed that poor adherence is a kind of serious threat to long-term therapies, especially like cases like hypertension, HIV, diabetic patients. Because it is not simply taking medicine at a like right time or at a right amount of amount, but it also refers to the lifestyle change, as well as willingness on the part of the patients. So like broadly, medication adherence includes like keeping appointments, meaning it is not sufficient that patient should follow whatever prescription or suggestion provided by the physician, but they should keep appointment, take medication at a right amount and right time, following a prescribed diet and executing other lifestyle changes. Means if a physician prescribes to a specific patient that you have to change your sleep pattern or you have to do more exercise, then they have to follow it. If they are not following, it comes under the category of medication non-adherence. Means patient is not following prescribed regimen which is prescribed by his or her physician. Then it has been observed that not only in say a developing country, but in developed countries, the adherence rate is between 20 to 50%. In developing countries, it has been observed that it is even much more, though as already mentioned in the beginning, that not much research has been done in this area. What kind of outcome may happen if there is a non-adherence? So if the first outcome will be that there will be greater morbidity, and consequently there will be greater mortality among patients. Not only that, there will be social cost, economic cost, and psychological cost as well. Like previous studies have shown that if there is a increase in non-adherence, then the cost of health multiplies, as well as there will be a lot of comorbid condition, which again add in creates more problem for the patient and caregivers. Some statistics or I would like to mention over there that around 10% of hospitalization in older adults caused by medication non-adherence. Means even though there is only one kind of problem, or a person is suffering just for one single disease, and if the patient is not adhering prescribed regimen, then will be increase of hospitalization of around 10%, especially among elderly population. Then non-adherence to psychoactive medication in elderly individual is around 30%, and in case of depressive cases, it becomes even more. And it has been observed that approximately 25% of prescriptions are never picked up from the pharmacy. Means they go to seek their physician, but whatever is prescribed by physician, patient may that they generally don't listen. And it has been observed that it comes up to around 25% of the cases. What are the factors which may influence adherence, or you can say non-adherence? The first one is medical condition, second is medication condition, third one is personal, and fourth factor is economic condition. So we can understand very well that what economic condition or factors may influence. So if somebody does not have the capacity to pay, ultimately it cannot be considered non-adherence in a strict sense. Rather than since individual does not have the capacity to pay, he doesn't follow the prescribed regimen, or even he doesn't seek physician. What are the medical condition? It's like individual's cognitive abilities and all health basically determines whether individual will be like say will adhere, or he or she is not going to adhere medication. Then what are the medication kind of condition? It is like dosing frequency, complexity of the regime, and presence of side effect. So if there is a side effect of any medicine, the chance is that the patient may not follow the prescribed like may not get prescribed frequencies of the medicine, and patient may skip of taking medicine. Then personal factors may include like a personal belief towards prescribed medicine. So if somebody does not believe in any kind of system of the medicine, whether it's a allopathic or homeopathic or any other kind of pathy, then the chance of adherence is quite less as compared to when individual has firm belief towards a specific kind of pathy. Then within the kind of personal factors, memory and intellectual ability is another factors which may affect adherence behavior. And I'm going to discuss about this issue, basically that personal factor as well as medical factors. Apart from that, the kind of relation that patient and physicians have, that also determine adherence behavior. In the next slide, I would like to highlight some of the points which are basically part of these four factors. They're like such as like low health literacy, unclear or misunderstood medication instruments, impaired cognition, lack of social support, forgetfulness, and complex drug regime and high pill burden. So like if you see like unclear or misunderstood understood medication, again it is a kind of part of cognitive abilities. If a patient is not able to understand a specific prescription, the chance is that individual may not be like say high on adherence. However, like similarly the case of like impaired cognition, if individual is not able to understand the prescription, obviously there will be no adherence. Then that's the social factor, that is lack of social support. If there is a lack of social support, the chance is that individual will not be like high on adherence, rather than individual may not adhere at all to take medicine or prescribed regime. Then concern about side effect, which I have already discussed in the previous slide. Low perceived or need or efficacy, if individual perceive that there is no need to take medicine, or if individual believes that this medicine is not going to change his health or her health, then there will be low adherence. Cost of, obviously we have understood in the previous slide that economic cost is altogether different story, where individual is not able to pay for the medicine or for the service. And limited patient engagement in treatment decision. So if patient is not involved in the whole process, then the chance is that patient may not be adherent towards any kind of prescription. The next slide, I'm going to talk about how this adherence and age are related. So first, I would like to explain what does it mean by aging, and then I'll come to a little bit about prospective memory, and then we'll discuss about how this prospective memory, aging, and medical adherence are related. So aging can be defined as a progressive generalized impairment of function resulting in a loss of adaptive response to a stress and in growing risk of age-associated disease. Recently, it has been observed that like the older population, 60 and above, is around 138 million. And we are now around 10.1% of total population who are who are basically elder or older individuals. Like 10 years back, it was quite less. It was around 7.8%. But now slowly even India is growing old. And it's a kind of process which is happening all over the world. So that is why this understanding medical adherence or non-adherence becomes even more important issue. So increased longevity has resulted in aging world, not only in India but throughout the world. So how aging is related to adherence? So older adults are faced with a challenging comprehension and memory task. So what they are supposed to do, so they must comprehend the information on the different prescription labels and integrate this and develop a complex schedule. It has been observed that older patients are having more than one disease or disorder. So they need to basically comprehend information for different kind of medicines, and they have to integrate, and it requires a lot of like cognitive resources, especially perception and working memory. Then after understanding the prescription and uh, different timing, a different schedule, they elderly population has to remember the schedule for taking medicine, when they have to take medicine, in what condition they should not take, and which condition they should take medicine, and other issues. Then older adult must remember to take the medication at different prescribed time. So if you clubbed it in terms of cognitive factors, what cognitive factors are involved in comprehending prescription, understanding schedule, and understanding when they have to take medicine and in what amount, we can basically club these abilities in terms of working memory, long-term memory, and prospective memory. Even episodic memory has been like kind of uh, working that episodic memory also plays significant role in this process, but it is clubbed with long-term memory. And what working memory is supposed to do, basically it helps in comprehension of instruction, integration of information across medication to develop a daily plan. And in long term, basically it helps in preparing of written record of the plan, and remembering to take the medication when they are supposed to take medication, in under what condition they are supposed to take medication. It is done by or it is done with the help of prospective memory, which I am going to talk in the shortly. So working memory and long-term memory along with the episodic memory, like it has been observed that these two kinds of memory decline with age, and it is quite well established. But when it comes to prospective memory, literature is quite like say divided. Some of the studies have mentioned that aging and prospective memory are positively related. Other it has it was found that as individual age, there is a like say improvement in prospective memory, means there is a negative relationship. So later on was clarified that there are two different kinds of, or basically three kinds of prospective memory. It has been observed that in case of time-based prospective memory, there is a positive relationship between aging and prospective memory. Means as individual age, there is a decline in time-based prospective memory. But when it comes to event-based prospective memory, there is a kind of like say debate is still going on. You may ask question at the moment that what does it mean by time-based and event-based prospective memory. I'm going to talk it quite shortly. So, but before that, I'm going to talk about a little what does it mean by prospective memory. So prospective memory is memory for action to be performed in future. Basically, it is an intention based, and if you see, intention can be of two kinds: intention in action or delayed, like say prior intention. Prior intention is divided into two, like immediate or delayed intention. So prospective memory basically covers delayed intention, and it can be defined as a memory for realization of delayed intention. Example can be, if you see the PPT slide, it is like delivering a message on seeing a friend, or remembering to take medicine or attend a meeting at a particular time. One of the important thing in prospective memory is that there is no obvious external cue uh, to realize prospective memory task. Unlike there is another kind of memory which I will discuss shortly, that is called retrospective memory. So retrospective memory is a memory, basically whatever you have learned in the past, or whatever you have encountered in the past. So it is past oriented, and when more like in examination like situation, you need retrospective memory. When somebody asks you directly, what does it mean by this or that, so there is a cue that you are asked to do, or you're asked to reproduce something. But in case of prospective memory, there is no such external cue. It is self-initiated, and you have to monitor uh, all the time that I'm supposed to do a specific task at a specific moment in time. And that is why as I already mentioned, that in elderly population, time-based prospective memory declines as individual gets older as compared to retrospective memory or even event-based prospective memory. There is another difference between prospective and retrospective memory. Like we understand that prospective memory or memory has 3 steps, like encoding, storage, and retrieval. However, in case of prospective memory, there are basically 5 steps. First step is formation and encoding of intention and its associated action. Then there is a retention interval, like it is a time period between encoding of intention and remembering that you have to perform a specific task. Performance interval is a, like example can be like it may look or it may appear a little bit confusing, that what is the difference between retention interval and performance interval. So retention interval is like you encode something, like for example, you decide that after this meeting I'm going to talk my friend on phone. So what you have to wait for this talk gets over. So that is basically your retention interval. Then after the meeting, you may decide immediately, or you may not remember that I had made intention that I have to call my friend, or you may remember that you now I'm going I have decided, or I had made my mind that I have to call my friend. So once you remember that you had made an intention, that period is called performance interval, when you start basically performing or executing your intention. So that is performance interval. However, when you actually execute, when you you actually call your friend, that is your execution of intended action phase, that is fourth phase. And unlike retrospective memory, where there is a encoding, storage, and retrieval, here there is a fifth stage, that is called evaluation of outcome. And here you you can basically evaluate your performance, whether whether you were successful or unsuccessful in executing your intended action. So again, I will discuss shortly what kind of evaluation one may uh, uh, take. Like just a hint, there can be 2 kinds of error over here. Either you are successful in executing your intended action, or there can be either omission error or commission error. What can be the case over here, that you may miss, like said, you are so involved in the talk or with or the other thing that you forget and you assume that I have already spoken to my friend, or you may wrongly remember, you may wrongly remember that you have not called your friend, and uh, you call him again or her again. So there can be omission error or commission error. I will elaborate this issue later while talking about um, medical adherence further. So a little bit distinction, elaboration about what is the difference between prospective and retrospective memory. So prospective memory, as if you see the PPT slide, it is like it looks like it is intention based, future oriented, self-initiated. It requires monitoring. It requires planning. However, retrospective memory, it is assumed that it is content based, past oriented, and it is external. It requires external cue. So as already mentioned that if you learn something since I assume that most of you from psychology background, if I ask you what does it mean by perception? What you are going to do, basically you are going to use your retrospective memory and you try to retrieve from your past experience or past learning. Here like what you are doing, you are retrieving content. It happened in the past and there is an external cue. I am asking you, so there is a cue, me as a cue. So everything is clear. But in case of prospective memory, mostly it is intent based, that you are executing your intention. It is future, like say you make intention now, you may execute either after 1 hour or after 2 days or after 2 weeks. It is self-initiated, means nobody is going to provide a cue to start or to execute your prospective memory task. And you have to monitor the situation to judge when I am supposed to execute my prospective memory task. So monitoring is required, and you have to plan when you are supposed, when you can basically execute your prospective memory task. In the beginning, I mentioned that there are two kinds of prospective memory. Basically, there like some researchers are of the view that there are three kinds of prospective memory. So there is a time-based prospective memory and event-based time prospective memory. Time-based prospective memory requires of execution of time-based prospective memory task at a specific moment in time or a specific time, like taking medicine at 9 p.m., 6 p.m. or 12 p.m. Similarly, event-based, but here there is a subtle cue, like previous example, that delivering a message to your friend. So if I ask you to deliver a specific message to your friend X, it's a kind of seeing that person is a subtle cue, but it is not obvious. Somebody may say that, okay, there is a cue, but that cue doesn't ask you to hand over the message or to deliver the message. So even though event-based prospective memory looks like that it is there is a cue, however, this cue is quite subtle, it is not obvious. Some researchers are of the view that there is a third kind of prospective memory, and that is called activity based. And here the realization of prospective memory happens after finishing a specific task. Like, so taking medicine after dinner is a activity based, that one activity gets over and then you start executing your prospective memory. So if you see whether it is time-based or event-based prospective memory, in both the cases, you have to stop your ongoing task in order to perform time-based or event-based task. But in case of activity-based, there is no interruption, and that is why it is easier to execute. All right. Then comes like in case of especially that prospective memory and medical adherence. So here you make kind of intention that I have to take medicine or somebody has to take medicine. Either it can be based on say time based, like somebody has to take medicine at a specific time, like 6 p.m. or 9 p.m. In this side, it can be based on some cue that, okay, you have to take medicine while watching 9 p.m. News. So it becomes event based. So you can basically patients can change time based task into event based and event into time. Then queue detection and intention retrieval. As already mentioned, queue there may not be queue, and if there is a queue, that queue will be quite subtle, and then you recall what you are supposed to do, and you execute your intention. In this case, take intention of taking medicine at a specific dose or a specific number of pills. Now, like earlier I mentioned that I will be elaborating a little bit about this omission and commission error with respect to prospective memory. So if you see that PPT slide, patients perceive forgetting as a common reason why they do not take prescribed medication. There are 4 ways where a patient may commit errors. One is omission error. So a dose was omitted from the plan, and this omission is may just be because of prospective memory failure. Patient may wrongly remember that he or she has already taken the medicine, and patient does not take medicine. In commission error, an extra dose that was not prescribed was taken. Just by it is due to prospective memory failure. Individual may wrongly remember that he or she has not taken medicine and take another dose. And this in both the cases, it is quite say harmful for the patient. So if there is a problem in prospective memory, these 2 kinds of errors may occur. Then in case of that, especially in the context of non-adherence behavior, quantity error may happen and time error. So in case of quantity error, a dose was recorded in the incorrect amount. So either patient may wrongly note down that, okay, this much amount I have to take, or may wrongly take that. While taking pills, patient may not be able to judge accurately, and as a result may take incorrect dose or incorrect amount. Then time error. Patients deviate by a substantial amount of time to take medication. Means patient is not able to remember accurately or correctly that he or she has to take medicine at 6 p.m. not at 6 a.m. So that is time error. So there can be these 4 kind of mistakes or error in case of medication adherence, non-adherence. How one can assess that adherence behavior? That there are different ways. One is counting pills. So the physician may give a specific number of pills, and then after 1 week, he or she can just check how much medicine have been taken. Then pharmacy record, like when the medicine was taken and things like that. That can be another way to assess adherence. Serum and urine drug levels. So it is just by assessing urine and serum, like by taking blood, because if somebody is taking medicine, there will be different different nutrients and other blood like there will be minuscule changes, and that can be another way to assess adherence. But the problem of these, like whether it's a counting pills, pharmacy record, or serum and urine drug levels in the like serum in the blood, or medicine in the urine, it is like not very accurate way to do that. Then clinician rating, again it is subjective, and clinician may not know like whether accurately whether a patient is taking like prescribed medicine or not. Then there can be self-report, and again there is a problem, because a patient may not like say accurately tell how much and when he or she is taking medicine. So one of the problem with assessing non-adherence or adherence is the method. What kind of method one may choose or take to assess whether somebody is adherent or non-adherent towards a specific prescription. There are some questions. I will come back after finishing the question. After finishing the talk. So I will go quickly about one of my study where, like say, we try to find out basically like effect of aging and prospective memory, and then I'll be taking questions. So the objective of the study was to investigate the effect of aging in medical adherence, to investigate the effect of aging in prospective memory performance, to compare performance under two kinds of prospective memory, that is event-based and time-based, and to investigate the role of prospective memory in medical adherence among elderly population. So this was the inclusion and exclusion criteria. Elderly men and women 50 and above, living independently, taking that chronic daily medication, voluntary participation. Exclusion was assistive living, and presence of chronic condition making 1 year survival unlikely, no psychiatric condition. Basically, in this study, we have taken both objective measurement and subjective measurement. So I will discuss each one separately. So the paradigm of studying prospective memory is that first we have to instruct to the participants, and then give unrelated task. Then there will be concurrent task, and within concurrent task, prospective and say event-based and time-based prospective memory is embedded. So like whenever you see a specific target on the screen, you have to click the mouse, or after like a certain period has elapsed, then you have to click on the screen. So that is how that objective is or experimental study of prospective memory is conducted. Then there was another along with that there was a questionnaire, and there were around 193 participants, and there were four groups of participants, like say from 16 to 25, 26 to 40, 41 to 55, and 50 and above. That age range was from 16 to 70 years of age, with the average is being 40.80, and standard deviation was 16.74 years. Morsky scale was for this to assess level of adherence, and Cambridge prospective memory test was for like event-based and task-based, event-based and time-based prospective memory, and that prospective memory questionnaire was for the larger population where the four groups were involved. So that mixed factorial design was used. Independent variable was in this analysis, prospective memory and age, and dependent variable was medical adherence. So this was the procedure, like say participant contacted a community dwelling and from old age home. That non-verbal test was conducted just to screen out whether there is any intellectual disability. And then the Cambridge prospective memory test was administered. So analysis of variance was conducted on age and medical adherence, and it was found that there was a significant effect of age, and it was found that age group 55 and above showed highest non-medical adherence, followed by age group of 41 to 54, and it's a kind of inverse relationship between aging and medical adherence, and that is understandable. So this is the mean and standard deviation of age and medical adherence. So if you see that 16 to 25 this and 26 to 40 11.52, 11 to 41 to 54 10.98, and 55 and above this much. So then comes that Cambridge one, another study. A mixed factorial design was employed to investigate the effect of age on prospective memory. All main effect was significant. Main effect of prospective memory was not significant. Interaction between age and prospective memory was also not significant. So age was significant. So if you see over here, different age group, 55 and above was was lower as compared to 16 to 25 age group and 26 to 40. And as individual gets older, there is a deterioration in the prospective memory as well. So prospective memory failure, these are the findings. So prospective memory failures were rated as more frequent among age group of 55 and above. The larger errors in prospective memory in the age group 55 and above can be attributed to cognitive decline in old age. So basically, whether it's perception or attention or executive functioning, because in prospective memory, you need planning, monitoring, and it is also part of that executive functioning. So as individual gets older, there is a deterioration in these abilities. It is understandable that there is a failure of prospective memory among older population. So age group of 16-25 and 26-40 years and above were found to lowest on non-medical adherence. There was positive and significant correlation between medical adherence and event-based prospective memory. However, when this correlation was conducted, there was no correlation between time-based prospective memory and medical adherence. Then comes limitation of this study. The study was self-report as a level of medical adherence. This may not reveal true nature of adherence, and there is a need to tap medicine taking behavior in naturalistic setting. But the problem is, it is very difficult to assess medical adherence. Like I have mentioned that whether it is a self-report or pill counting or serum and urine level assessment, it's like there is no full proof way to assess non-adherence or adherence behavior, and due to that there is a problem. But now new methods are being devised by some researchers, but it is still kind of people have started using. We are waiting for the replication. So that is it from my side. Thank you. Questions?
All right. Thank you, Professor Khan, for delivering an amazing session and sharing some really interesting findings from your research.
Yeah.
I would now like to invite Dr. Ehsan Ahmed Dar to take up the Q&A session. Over to you, Dr. Ehsan.
Thank you, Dr. Ninad. So, sir, there are a few questions that the audience has audience wants to just confirm from you. So, the first question I would like to just talk about is that out of the many chronic diseases which are prevalent today, so which chronic disease has the immense adverse effect on the memory?
It's there is no straightforward answer to this, because whether it is a hypertension or diabetes, diabetes or even HIV, all these are affecting memory, and especially prospective memory. because I'm talking over here about prospective memory, but it is not that there is a one-to-one relationship and there is a one disease which affecting more than the rest one. Because if somebody is having hypertension, for example, there will be change in a sugar level as well. Even your teeth may affect your memory, and your affect hypertension. It may affect your Alzheimer, like say some diseases, like old age disease like Alzheimer, Parkinson's. So health should be understood in totality. It is not that just one specific disease is having maximum effect.
Oh, thank you, sir. Sir, another question that has been raised is that how to handle the people with the medical disorders, sorry, mental disorders.
Yeah, actually, Samir Ali has asked like how to tackle depression, and yeah, a few days back in my lab we are discussing about like how we should do that. I'm going to repeat that. Even my lab members are listening me, and so it is like you have to enrich yourself. It is not that it's a like. Uh, that if you do this thing, a specific thing, like having a lot of friends may like say delay your depression, but it is not just one thing. Or like reading literature, for example. It is like how you are looking yourself, how you are situating yourself in your day-to-day life. That will basically kind of may delay depression. I'm not saying that do whatever you want, but if something happens, it is like a trigger point. Anybody may break down, but the best way is to enrich your like say yourself. That is my personal opinion.
Okay. So, sir, next question, as you were talking about the errors in the prospective memory, so are there any techniques or ways to improve it?
For prospective memory, yes, like say there are 3-4 centers. In one center I'm involved, like say Mark McDaniel. Actually, he is the person who started this area, like prospective memory. Like in 1970s, there was only one paper on prospective memory, but it was not mentioned as a prospective memory. The first article came in 1990s. So we are in the process of developing a tool, but there are other researchers who have developed there is an Australian researchers who have who has developed this tool. It's a kind of how you like basically enhancing your attention capabilities, your executive functioning and so on. So but still like it whatever has been developed, it is up to research level. Now they are trying to make or to apply it in day-to-day life. Hopefully even me and my collaborator, like say I mentioned about Mark McDaniel, we will be able to, he has done a preliminary work like say for the research. Now we are for the like say for applied part.
Okay, thank you, sir. So last question, which is from my side, that can you please tell us something about the dementia and the memory here, because the elder people are mostly affected with this.
Yes. Actually, one thing about dementia is it's quite you can say coincidence. The other day we were discussing about this. Okay. So dementia is not a single disease. Like say there is a Alzheimer. Alzheimer is basically the major portion of dementia. There is a Parkinson disease. There is a frontocentral dementia. There is a kind of Lewy bodies. So they have like 5-10% contribution. But in India, we have more recent studies have shown that we have more frontoparietal dementia. Frontotemporal, sorry. All over the world, it is like just 10%. but why it is so? Like what are the causal factor? Actual causal factor are not basically like they are saying that okay, there is a accumulation of amyloid and tau protein in the brain. So amyloid is outside of the neuron and tau protein is inside the neuron. And if there is a more deposition of these proteins, like there is a problem in the memory, or there is a problem in cognitive functioning of elderly population, especially after 60s. But if somebody is 80 years, the chance of developing dementia is more than 30%. Like in this context, I mentioned about when you ask about that cognitive decline, that disease and prospective memory problem. So even in case of dementia, even your that teeth health may predict whether somebody is going to develop dementia or not. Okay. And the worst part is that we don't have any national policy for this. And I shared this to my students as well. And in only that there are 6 centers all over the country, and all of them are situated in South India, except one, which is in Maharashtra. If somebody develops dementia, there is no center except these like 4 or 5 states. If you go to Uttar Pradesh or Bihar or West Bengal or anywhere, so it's a very sad state of affair. Though we have this Mental Health Act 2017, but we don't have any specific policy for this dementia, which is, though, like in terms of mortality and other problems, it's a high number. Though we don't know how many like are dying due to dementia. And again, due to this, it is not a problem of that they are not dying, but we are not counting them. There are not many memory clinics, unlike abroad. So if, like, suppose if somebody is having propensity towards developing dementia, for example, so what is happening? Like when it comes to frontotemporal dementia, it may start even before 60. It may start like say mid 40s, but people start treating that as a normal aging process. Like if they forget something, or if they are not able to reach a specific place, they think that okay, I'm getting old. They are not. They don't accept it as like they are having some problem or they are going to have some problem. So that is the issue. Did I answer your question or not? Because I started talking too many things.
Yes. So more elaborately, you have answered my question. Yeah. So what would be the policy implications on the basis of your research findings as far as India is concerned?
Actually, as already mentioned that we are in the process of developing some intervention tool.
Yes, sir.
So if we'll be able to develop this tool, at least we can provide some solace to elderly people that if they are using this tool, at least they will be able to remember important things in their life, including taking medicine.
So thank you very much, sir. So over to Dr. Ninath.
Thank you.
Thank you, Dr. Ehsan. So let me deliver the vote of thanks. First, on behalf of SRM University AP and the Department of Psychology, I would like to thank Professor Azizuddin Khan for delivering an insightful session despite his busy schedule. So we look forward to have more such engaging sessions with you in the future. I would also like to thank SRM AP University for their generous support. Particularly, I would also like to thank our Dean, Professor Desikan. Also, I would like to thank the ITKM and Communications Department for their unstinted technical assistance. I would also like to thank my department colleagues, Ms. Aisha Parveen Harun and Dr. Ehsan Ahmed Dar for their active involvement in the event organization. Finally, I would like to thank the audience for raising some really interesting sessions and making this event a grand success. I look forward to have you all attend more such events organized by the department in the future. Thank you. And have a
Thanks,
great
Ninath. Thanks.
Thank you, sir.